talking instability in this vignette, we're turning our attention to the most favored nation projection, the coronal projection, the one everybody loves. It's the easiest to look at because you're all used to looking at AP radiographs of the shoulder. So I prefer to have a pair of coronal projections. And if you're a novice or a beginner, it might not be a bad idea to have 3 coronal projections. The coronal projection should parallel the long axis of the scapular spine and scapular body. So it shouldn't be a straight orthogonal. In other words, your coronal shouldn't go this way. That would be a big mistake. I like to have the arm at the side with the thumb up in the neutral projection or the neutral position. Occasionally, it'll be necessary for you to stretch out the anterior glenohumeral ligaments, which are right here, and also to stretch out the labrum, which would normally be right here, although it's absent because the patient has an ALPS lesion or an anterior labral periosteal sleeve avulsion. But the reason we want to stretch it out is sometimes there are partial rim tears or partial rents that we can't see, and the best way to stretch it out is to do a special view called an ABER view, an abduction external rotation view, also known as the Deion Sanders view in the United States. So you put your hand behind your head, your elbows back, and this stretches out the anterior band of the IGHL, and also the capsule is taut on the labrum, so it pulls or tugs a little bit on the labrum and lays it out for you. Now, I don't do that in every case, only in certain difficult instability cases where I don't get the answer straight away. So it is actually not part of my routine exam, although I will bring it back, or sometimes I'll prescribe that it be used if somebody has a specialized form of instability. And what do I mean by that? Well, they might have relative instability, functional instability, partial instability, micro instability. These all mean the same thing. And what do they mean? They mean that the patient has not dislocated and they haven't locked. Who gets this? People with arthrosis, people with repetitive low-grade trauma. Who gets the acute type of unidirectional instability? It's usually the collision athlete. And then there's one other subgroup that you should dial into, and that's the family of patients who have dysplasia, where the glenoid is malformed or the humerus is malformed. Glenoid more common than humerus. So now let's return to the coronal projection. I like to have a T1 weighted image, and right next to it, my favorite sequence is a very heavily fat-suppressed PD, or proton density. What type of fat suppression? Well, that's up to you and your scanner. You've got spare, you've got special, you've got spur, and you can even use STIR, short time inversion recovery, at low field. But what I don't want you to do is I don't want you to lengthen out the TE. In other words, I want you to keep the TE in the middle, where you get the most robust signal and therefore the most robust water intensity. And what's that? About 40, 45, no more than 50 milliseconds. If you start going above that, now you're into T2 territory. If you're going to add another coronal, okay, you can add a T2 if you're a novice or a beginner, but I prefer to be practical, and I will use my T2 fat suppression imaging in the sagittal projection so that for the most part, in 95+% of cases, I can get away with 4 sequences: an axial GRE, high-quality GRE, a coronal proton density fat suppression, a coronal T1, again, they're angled along the axis of the scapula, and then a sagittal that's going to be orthogonalized this way, and that can be your T2 image. So your T2 fat suppression image will have to be cross-referenced with these other images to get a good feel for the status of the cuff, the nature of rotator cuff tears, the depth of tears, etc. Now, since we're talking instability, the coronal projection is invaluable in instabilities that affect the superior and inferior labra. That makes perfect sense, right? You're perpendicular to these structures. So anything going up this way, easy to see. Anything going down this way, easy to see. So for axillary injuries, like Hegel lesions, humeral avulsions of the glenohumeral ligament, in other words, this avulsus from the neck of the humerus, or bony Hagels. Or in this case, we have an axillary IGHL tear. And in this case, we also have an ALPSA lesion, an anterior labral periosteal sleeve avulsion, where the labrum is slid underneath the periosteum as a macerated structure. Pay no attention to this globular thing, which is coagulated blood, which might easily confuse you. So it's obvious. You know, coronal projection, when we go high, then we go low. We go high, we go low. On the T1 weighted image, we have our best view of any bone pathology. For instance, we've got a hatchet job on the superolateral humeral head. We've got a pretty deep Hill Sachs. Now, I might not use this projection to assess the percent of involvement of my humeral head. I'll use the axial projection for that. We'll talk more about that in individual cases. But I will use it to see how far medial or lateral my Hill Sachs is. The more medial the Hill Sachs lesion is, the more problematic recurrent dislocation may become, and we'll see why that is in other vignettes. Obviously, the bigger the Hill Sachs, the more problematic recurrent dislocation is as well. But this is your Hill Sachs projection. Now let's turn our attention to Hill Sachs for a minute. Remember that Hill Sachs fractures were called fractures because, you know what? That is all you could see with conventional radiographs until MRI came along. And then you could see microtrabecular injuries. So this one's easy, right? It's a depressed fracture. But what if you had an intramedullary and chondral bone, medullary bone abnormality? You'd see nothing on X-ray. But you would see it very clearly as an area of low intramedullary signal on MRI and high intramedullary signal on PD, SPER, SPARE, or special. Again, this one's easy. We got a depressed fracture of the superolateral humeral head. So this is your Hill Sachs view. This is your axillary labral injury view. This is your inferior glenohumeral ligament view. This is your view to see the labrum axis medial to lateral as opposed to anterior to posterior. And the T1 weighted image is going to help you cover your bone pathology. So that concludes our discussion of the coronal projection. You know, there'll be other things that you're looking at as a general search for a general shoulder examination. You're going to be looking at the subacromial arch, the coracoacromial ligament and its size, which comes off right here. You'll be looking at the AC joint, the size of the muscles, fatty infiltration, the configuration of the glenoid cup, the shape of the humeral head, whether the growth plate is open or closed, whether there's any masses in the spinal glenoid notch or rim, but that's a story for another day. But a quick review. Let's have a look at the companion vignette, the sagittal projection.